there we are, tips and tricks for making great dentures. So yeah, if you have any questions at all, please just pop them in chat. We love loads of questions. And also, maybe if we'll put it onto, we can unmute you and you can ask a question if you want as well. That's absolutely fine. We can do that live at the end. So here we go. So the first thing we think, the most important tip is really great communication, with the patient. We get so much, I get so much feedback from my patients, and I've just got to find out what they're wanting. And also it's really important that I communicate very clearly to the patient what the limitations are with what we're doing as well, because there are always limitations with dentistry and removable pros in particular. But I think also another massively important thing is great communication with the dental technician. I think that's really key to being able to produce fantastic dentures. What do you think, Sam?
Definitely. I think information transfer is something we talk about a lot at the practice. And the more information we can have in the lab, the better results we can produce for Finley. So it's definitely about transferring as much information, pictures, designs, everything like that over to us.
Absolutely. That's definitely. So, and then the other thing is that, I think importantly, particularly as a young dentist, if you're really interested in going down the prosthodontic route, both removable or fixed, I think it's dead important to find a great technician, because it's particularly, about 20 years ago, I met Rowan, and I met him when I was doing a master's program at Manchester, and we just got on really well. It's a bit like a marriage. We've worked together for 20 years now, and we've grown together and we've learned things together. So my recommendation is, as a young dentist, find a great technician and stick with them. And then you can both go on this learning journey together. It's absolutely fantastic. So I've worked with Rowan for the past 13 years in the practice together. We've worked together in Garstang, and Rowan works in the room next door to me. So I've got my surgery, and right next to it is the lab. And Sam has just joined it. Well, Sam's been part of the practice for a year now. And Sam's learning from Rowan too. And he's really, really talented. And he's talking tonight to us. So Sam, you're going to say something here.
I mean, in the space of 12 months, working at the practice. You still there, guys?
Sam, you just were breaking up just a little bit. Just repeat that, please.
Are we back?
I can hear you.
I was just saying, in the space of 12 months at the practice, the quality of my work has just, become so much better. And opportunity to go on clinic and actually the processes that I've learned that has really helped me in my career and to push myself forward in what I'm doing in the lab.
Absolutely. That's brilliant, Sam. Thank you. So, and then the other thing I think is a really important tip is to find a mentor. And I've learned so much from lots of different mentors throughout my career, but over the past 10 years, I've had John Besford as a mentor for me, and he is probably, I think he's probably one of the finest denture making dentists ever in the world. And I have a meeting with him. I have a Zoom call or a phone call every week for an hour, and we just chat about loads of stuff, and he critiques the cases that we do at the practice and helps us to improve. And we love this journey that we're still on, this of improvement. So I think this is a really important point as a young dentist. in a discipline that you want to go down, find your mentor and stick with them, learn as much as possible from them, because they've got so much information, they've got so much experience, it's unbelievable. And that's what Sam's getting from Rowan now. Sam, are you
having
there?
Rowan in the lab is can you hear
Sam, you just
or am I still all there?
it's just a little bit, it's not great. So
bear with me, I'll carry on without me and I'll rejoin the meeting.
That's absolutely fine, Sam, no problem. So I'm going to get straight onto some technical stuff and clinical stuff. And I want to just talk a little bit about immediate dentures. And I wanted to introduce Xavier to you. I saw Xavier last week, and what I did was I took out these 3 upper front teeth there for him. We'll have a little look in his mouth there. So he's got periodontal disease affecting these anterior teeth, 6mm pockets. He's a smoker, and they are needed to, and the sort of life expectancy of them is really very limited. So what I wanted to do was to take those out and put an immediate denture in. The plan was to do an acrylic based immediate first, and then we'd move on to a chrome. But I just saw him last week for fitting the acrylic denture. But my job is to give Sam and Rowan a superb impression. And this is a little tip that I find really, really useful, is when I'm doing an impression, and particularly in a patient like Xavier with quite a deep vault of a palate, then what I do is I put a lump of red compound. This is Kerr red compound. Soften that up in water, put it into the middle there, and then push that up into the mouth. And it just helps me locate this right in the center of the palate there. So, and this is what I've done here. So on top of that, so once I've done that compound, I do another impression in alginate over the top of that. And that helps me to record all of the lovely detail that we need. I need to record all of these teeth beautifully. I need to record the sulcus, particularly around this anterior area, because that's where we're going to be taking the teeth out. So I've got to give Rowan and Sam this great impression. So I'm going to just have a little look to see if Sam has joined us again, because I think he might be having some internet issues. I can't see his name in the participants at the moment, but I will just keep an eye on my WhatsApp. That's fine. Okie dokes.
I think he's just joined in again.
Is he?
I think it's just popped up.
Thank you, Giovanni. I'm just going to find him on that list.
Here we go, am I back?
Good lad. Hooray.
There we go. Sorry about that.
That's okay. So, Sam, what I've just talked about here is just getting a really good impression for you. And then it's over to you now just to chat about what you do with that.
Yeah, I mean, once we receive this into the lab, especially with partial dentures, I'm really focused on accurately reproducing any of these denture-bearing tissues and structures. Partial dentures, our main focus is the teeth and kind of the crest of the ridge. When we come to doing full dentures, then the periphery becomes a lot more important. From that, we end up with a cast that looks something like this. And for doing immediate dentures, we then remove the teeth from the cast. And this is another point where we need to have really good communication with you guys on the clinic, because I need to know exactly how much you're prepared to remove tissues and things in the mouth, bone spikes and things like that. Generally, we'll prep a socket about 1 to 2 millimeters anteriorly, and then a little bit deeper posteriorly, and that should give you enough sort of room without creating difficulties fitting, if that makes sense.
So what I'll do is I'll just move forward to the prepped model here that Sam's just talked about. And you can see here that we've got these. This is what the teeth have just been basically trimmed away, and then it goes shallow, so it's about 1 to 2 millimeters depth. But as you progress into the site, it goes deeper. So it's really, you're just basically cutting out like a root shape. That's what Sam and Rowan are doing. But preserving everything else. But it's just really crucial to try and record all this detail that we've got everywhere. And then we cut a post dam on it. There you can see that post dam has been cut in there. So the denture is going to just sit into that tissue. Plus, you can see he's got this midline fissure as well. There's lots of stuff that Rowan and Sam and we talk about. Rowan, points out, look, he's got this fissure here. So I think we should, and he says, I think we should swing the post dam further forward to avoid that fissure, so it can seal that denture properly. So, but we'll go back to the denture there. Sam, you wanted to just chat about this, didn't you?
Yeah, a lot of immediate dentures, they are temporary appliances, essentially. But we take really good care in creating an aesthetic that the patient's going to be really happy with, because we find that no matter who's making the denture, the patient's first ever denture will be the one that they dislike the most. It'll be the hardest to get used to. All the hard work is being done with this first denture. So creating something that's aesthetically acceptable really helps the patient sort of psychologically getting used to this new appliance that they've got in the mouth. And you can see here, we haven't gone for a boring normal denture setup. We've kind of used a bit of an essence of what Xavier had before, and just kind of tried to improve him a little bit and give him something that looked really natural and really good for him.
That's it. So, and then if we have a look at the actual denture itself, you can see here that we've put in, what we like to do is we like to collet immediate dentures. So every tooth has a collet on it. It's all touching there, and this adds increased stability. I don't do this when it's a definitive denture. If it's a chrome, we try and keep everything away from the gingival margin, but this is a temporary appliance and we want it to be as stable as possible and as accepted as possible by the patient. We put 2 clasps on. These are stainless steel, 0.9 millimeter. They're on the furthest back teeth, so it just keeps it out of sight, when he's talking. I'll just fast forward now to last week. So this was Xavier on Friday when he came into the practice. So I gently took the teeth out, and I was thinking about doing this lecture. I was thinking about it whilst I was taking his teeth out, and thought, this is going to be great to talk about tonight in particular. So I've used luxators just to gently lever those teeth out, just to take them out as comfortably and as easily as possible. I've also opened a little gap up here. You can see I've just shaved a little bit of enamel off these 2 teeth just to widen that section there, and that to allow the denture to fit. So, but what I want to just share with you tonight, and I think this is a really important point and something that never got into my head at dental school. It took me ages. I always thought that whenever we got something from the lab, like a crown or a bridge or denture, it should fit perfectly without any adjustments. And that is so wrong. I've got to adjust almost everything that I fit in the mouth, because the model and the teeth are so different. So this is me at the fit appointment. So I've taken out Xavier's teeth. I've got this denture in there, and I'm wiggling it and just looking to see where it's fitting and where is it holding off. I'm visibly looking at that. So I'm just giving it gentle wiggle. I'm not pressing it down too hard, because I could be really in danger of pushing it really hard and fitting it down, not actually being able to get it out. So it's like it's just wiggling it and easing it in. And then what I do, pardon me, I take the denture out. Pardon me. I take the denture out and use this stuff, and I use Occlude. This is this spray here. It's absolutely fantastic. I use tons of it for fitting things. So what I'm going to do is, that's the nozzle here. I'm going to show you this little video. I spray the Occlude on every little surface that's going to touch the teeth. So what I do, I just work my way around the denture with this spray, and it goes on wet, but then it becomes like a dry powder, and it's brilliant. So I can then take this to the mouth, and then very gently, you can see this is a little video that's attached to my camera, my glasses. I'll just go back and you can see that again. What I'm trying to do is just gently ease the denture in there, and then I take it out and I look for areas that have been rubbed off. And this is a rule. This is not Xavier's denture, but this is it shows you my rule, which is adjust below the edge. I adjust below the collet on these bits that rub off there, using this type of a diamond. But what I do, I think about, is I never adjust the edge of the collet here, because that can create a gap between the denture and the tooth. It's a very, very important thing that I think about. And I'm so glad I know how to do this now, because it means the dentures fit really well. So now, I'm sorry this is a little bit bright, this video. This is from my glasses. So this is what I look at. So this is Xavier's denture, and often to get these things fitting properly, it's these single teeth that are a problem. You know, where you've got a natural tooth and an artificial tooth, it's quite difficult to get it to fit down. But what I'm doing here is just using a dry diamond, and I just look at the areas that have been rubbed off the Occlude, and I just touch those areas with the drill. It's quite a coarse crown prep diamond burr. It'd be one that you'd be using for, say, doing veneers with. So I just go around the denture, and wherever it's just rubbed off, just take a little bit off. And then I go back to the mouth and try that in, and I repeat that. And this, for me, for Xavier, this took me 20 minutes on Friday to fit it down fully. So I had to keep using Occlude on that fitting surface, in, adjust, and then Occlude, adjust, in. So repeating that until the whole thing fits down. And what this does is, as long as I avoid touching the collet where it touches the tooth, we'll always have a nice seal around the edge. So I'll very, very rarely will I touch the collets. It's all done underneath. So, and it fits it.
This is another, the fit is another aspect. Again, this is the first denture that Xavier has ever worn. So just eliminating the gaps and the things that his tongue is going to find, and creating something that's really comfortable and really nicely fitting, that will just help him so much in psychologically getting used to wearing dentures, because it is a big thing to get used to. And in this picture, you can kind of see, again, you know, this isn't a standard denture setup. We've really gone to town with tooth positioning. But another thing we can take from this picture is we use immediate dentures sometimes as our kind of prototype for our definitive. So we've made this denture here. we kind of had a look and thought the anterior teeth might be a little bit too light, maybe the shade's not quite right. And this is something then that we can make notes of, take pictures of, and then move forward to our definitive dentures with all this extra information.
Absolutely, it's great. So, and it's just so nice knowing that we're making it definitive later. So he was really delighted with that. So now Xavier's on this journey. So I'll be relining that partial denture in 2 months, but I've not done that yet for him. So we've got Wendy here instead. So here's Wendy with her. This is her immediate denture. And she wanted it quite light, actually, like that, by the way, because we'd taken out these old crowns that were A2, so we matched them up to those, and that's what she wanted. So I know that it's looking a bit lighter. I prefer to go down a shade just to make it match perfectly. But anyway, let's ignore that. 2 months later, the gums have shrunk, and it's ready for a chairside reline at this point. And that's my standard protocol, is we do a chairside reline. So I'll just show you how we do that. So everything's shrunk back. So what I do is, and this is a great tip that Rowan taught me, is to put wax onto the outside of these teeth there like that, and just leave a little border of the denture exposed. And then using this is Oofy Gel Hard. There's lots of reline materials out there. I quite like this. I think it's really nice. It works well. So pop that on, push that in, and then whilst it is setting, move it in and out so it doesn't lock in. You know, so just knowing the setting time and then moving that really is, that's the key to this. But you know what? This is 2 years ago, I got a denture stuck in because I totally forgot to move it in and out whilst I was doing this chairside reline. So this is Diane in the chair here, and it took me an hour and a half to cut it out. And the reason that it was locked in like this, it was locked in the mouth, was because I didn't take it in and out whilst it was setting. I totally forgot to do it. I think Claire and I started chatting about something and then just forgot to do it. And what an idiot. So I've got to really carefully drill around the area that's locked into the teeth just to release the denture. So I'm showing you this now because if you've not done this or made this mistake, I want to help you avoid ever making that mistake, because getting a denture locked in a mouth is very, very stressful. Because I had a patient waiting at the time, you know, so, but she handled it beautifully. You can see my face is really red. I can see my face I'm sweating whilst I'm doing this. So, but moving it in and out gently, and we can just do this. This is back to Wendy. I didn't get Wendy stuck in. So, and then that's fine just now, temporarily here, there. So we've got an extra little flange on there. First of all, I want to just share with you now, and just the little side issue, the chairside reline for a complete denture, an immediate complete denture, just a few little tips and tricks. So this lady here, this is Anne, and we can see just here where the denture itself, this is 2 months after extracting the teeth. You can see where the flange now, there's a big gap there. So how we do this is, Rowan, this is a great tip that Rowan taught me, is I put wax on the outside. This is just a sheet of wax, lay it on the outside, but leave a little periphery here. And then I put some adhesive in, Oofy Gel Hard adhesive, plenty of it on the whole thing, on the periphery, and then squirt in my futar, sorry, not my futar, the Oofy Gel reline material in there. You can see to take that in. And then we take this to the mouth. And what I do is I put that into the mouth like that, and I mold it. So it goes into the patient's mouth, hold it there, and I mold it just like a complete denture. But when I'm doing this chairside reline, what I want to do is to really fit it back down onto the palate, because you'll know that there's no resorption at all of the palate. The resorption takes place on the ridges and where we've taken out the teeth. But I want to push the denture right firmly back onto the palate so that the reline is not too thick, and so the occlusion is not altered with that. So it goes in, do all of that border molding, and then it comes out of the mouth like this. And the reason I've put this wax on the outside of the teeth is it stops the reline material from running incidentally into the teeth. And we can just peel off the wax like we've done there, and then trim the reline material back flush to the level of the flange, just like this. So we can just trim it nicely, and then that can just go, we can just take that back to the mouth like that. So we're now in a nice holding pattern. So my protocols for immediate dentures are 2 month chairside reline, 4 months lab reline. And this is when the dentures really improved with the lab reline. I just want you to talk you through that process. So at 4 months, the lab reline, so the denture looks like this. It all starts to look a little bit tatty because this is our chairside reline where the gum has shrunk away. And so what I do is I do a really good impression in silicone of the area where it's resorbed away at the front there. So I put adhesive onto the acrylic. So silicone adhesive, squirt silicone on, it goes into the mouth, and I make sure that the denture is fully seated onto the palate firmly and wait for that to set. So that's part 1 of this process. Part 2 is then taking a stock tray with alginate impression material in, and then putting that right over the top there, and then picking this whole thing up in the impression. And then this goes through to Sam.
So yeah, this is, like Finlay mentioned, having that denture seated down really carefully is massively important. My experiences from a commercial lab, I've seen some dentures that were nowhere near fitted down, and the lab just basically can't do anything with that. So that stage is super, super important. From here, we then cast a model into this with the denture in situ. We then remove the denture from that model once it's all set, and it should look something like this if everything's gone to plan. So at this stage, we can then start thinking about adding a flange, not only for aesthetics, but now we can really start to engage some of these tissue undercuts, some of these sort of the mesial undercuts of the canines there, and really create some nice retention and some nice aesthetics as well. You'll see on this next slide that we try to make the edges of our flanges very thin on partials. We're really trying to blend it in, and if we do our job correctly, it should look something like the photo on the next slide, where it really just blends totally into the patient's tissues. So I think that's pretty good.
So that's Wendy's, that's the flange there of Wendy's denture that, you know, with this reline. So this is a really nice thing now. So this is at 4 months post extraction. The patient is now in a great holding pattern now until we do the definitive denture. So I don't do any relines at all, or very much on the denture now, up until making the definitive. And I like to, if possible, make the definitive at 12 months after extracting the teeth. Because I find that most of the resorption has occurred by then. So that's really the key to this. So, and then when we move forward, so if we go back to Xavier, who we showed right at the beginning, what I've done right at the very beginning of actually treatment planning Xavier is working out and designing a definitive denture. Right from the word get go, this is what we do. We like to begin with the end in mind. And I love, and I really enjoy doing this actually, because it's designing dentures and colouring them in. It's like adults colouring in, which is like a stress relief for me. I find it's just lovely to look at photos of the teeth and look at models of the teeth and then design this and put in everything that we need to be thinking about in terms of the overall approach to this. And because we do this, the outcomes of the dentures are really, really good. Sam, could you just add your thoughts on this approach, please?
Yeah, definitely. I mean, starting the design phase right at the very beginning, before we even sort of start creating the temporary appliance, it gives us a lot of time, a lot of back and forth between the lab and the clinic, and we can really hash out any issues we think we might encounter along the way. Also, design sheets like this are so helpful because, as I say, us being technicians, not being chairside, not seeing that patient, just any little tiny bit of information that you can provide will always be a massive help to creating something that's really going to be successful.
That's it. So, and then, it just means that our finished products are really, we've really thought about them and it works really well. So this isn't Xavier's finished product because he's still got a bit of time to go. It'll be next year when we start making his. But we just love that approach of beginning with the end in mind, really, is the whole sort of approach. So I also want to just share with you just another top tip about fitting chromes as well. Again, expecting a chrome that has been fabricated to fit every single tooth in the arch, and it's a big casting, or it might even be a printed denture. These sorts of things are not going to fit perfectly on the model in the mouth. So my rule is that I try it in, and if it's not seating all the way down, then I adjust the areas above the contact where it touches the tooth. So any area above where it's colleted, we adjust it. So like these areas there, but so there and there where it rubs off. Again, using this coarse crown prep diamond is brilliant for that. And I never touch the this colleted area. It just means that we're not creating gaps between where the metal and the tooth surface contact. That's really, really important there. So great tip. I'm just going to now just share with you a little tip about, patients that have really pronounced gag reflexes. And I'm just going to show you this patient here. This is Liz here, and I was going to, and you can see this is me and Claire, and we're going to do an impression for Liz for an immediate denture. That bridge that you can see has failed, and I was going to be removing that at the next visit, fitting an immediate denture. But she is really nervous of the dentist, really hates having dental treatment done, and finds that having impressions made makes her really gag. And so very, very occasionally, and this is once every other year, And bearing in mind that I do lots of dentures, it's very rarely, but sometimes I use acupuncture. You can see there's a little needle just there, right in the midline, in this mentolabial groove there. So I've put that in there before starting the impression. And I'll show you this video of me taking the impression, but so I've put that in there. And also we really manage the patient really well. We rehearse the impression with the patient. We do a dry run beforehand so the patient knows exactly what to expect. Claire, my dental nurse, really participates on this appointment too. So she actually holds the patient's hand. If they're really super nervous, we find that if the patient holds the dental nurse's hand, it stops them from gagging actually as much as if they're just left on their own. So it's this comfort is really, really important. But anyway, you watch the video and you can hear us talking to the patient. We have a certain patter, which is like relaxing them. Here we go. So I'm just going to rub some alginate into the occlusal surfaces of the teeth. So breathe through your nose. Fantastic. Wiggle your toes. Seat up at the back, up at the front, forwards. Yeah, it's perfect.
Well done, Liz.
Wonderful.
Well done.
Okay.
Well done.
Nice. Just totally relax your cheeks.
Wiggle your toes.
That's it. Totally relax your cheeks. Fantastic. That's it.
Well done. Breathe through your nose.
That's it. Doing beautiful.
What doing? Brilliant. 40 seconds, we're nearly there.
Wiggle your toes. So you could hear Claire and I were just talking to the patient, trying to keep her relaxed. The other important thing is the patient sitting up in the chair, sitting upright, and that stops the material from going down the throat. And I do all of my prosthetic impressions with the patient sitting upright in the chair. It sort of works much better like that. So I hope that didn't put any family members that were listening, put them off there, surprise them with those horrible sounds. So now we're going to just talk about dentate pictures and how important they are. Having a really superb photo, Sam.
Yeah, the picture on the right, we have a little running joke. We call this a BSD, a British Standard Denture. So that's tiny teeth sat on the ridge. And it mainly comes from, it's not an uncommon result, and it mainly comes from not having a well-carved wax rim. So as dental technicians, you're given, two edentulous models, and you're not given much to go off. So you just have to use the reference points that you've got to try and create something that looks good. Whereas if I was going to give you guys one tip on improving aesthetics, something you can do in not a great deal of time, it would be to carve that wax rim. And if you do that, and that, again, information transfer, it lets us know where the patient's lip support needs to be, how much overjet, how much overbite. It's just such a valuable tool. And then having the dentate photographs on top of that just mean that we can go the extra mile and restore the patient to what they naturally would have had, which looks so much better than perfect, straight, bright white. We can create something that the average person walking down the street would never know in a million years that this patient was wearing a denture. And I mean, again, I think that's a great result, and it's how she would have naturally been if she'd have kept all her own teeth.
That's right. So, and like Sam was saying, it all it is just it's about me carving a wax rim, that looking at the dentate photo, and then that allows Rowan and Sam to put the teeth back where they were naturally. So getting that photo to them. It's all about carving this wax rim. And I love this system of where we've got basically it's a wax rim at the top, and I love lower pivots here. These are also known as Manchester rims. So it's like a full block, but with the central section cut out, and it just enables easier registration process. But the key to getting great aesthetics with this is all about this visit. You know, when Claire and I are looking at the patient, like Julie here, and we've got a dentate photo up on the screen here, and I keep referring to that whilst I'm carving the wax rim. But there's a recipe. It's a really straightforward recipe. And I'll share that with you just now. And it is absolutely the key to great aesthetics. So the first thing I look at and I carve, and Claire's part of this whole process. She's looking at the patient, my dental nurse. She's worked with me the past 13 years, and she helps with this whole process. And we have a constant sort of dialogue about this. So we carve the wax rim to get the right lip support initially. So that's number one. Number two, the second one is to look at the incisal plane and carve that parallel to the interpupillary line, if that's what we want. If the patient's incisal plane had a cant to it, then, and the patient wants that, they want to have it replicated in their denture, then we do. So it's all about a dialogue with the patient. But in general, we're looking to make it parallel with the interpupillary line. The third thing that's absolutely massively important is carving the rim, the occlusal plane, parallel to the alar tragus line. The alar tragus is the key to great aesthetics, and the upper rim following the curve. It helps this rim follow the curve of that lower smile by carving the alar tragus. Fourth and fifth, we trim the buccal corridors, and we mark on a center line with reference to a dentate picture, you know, like that. And then six, I trim the lower rim here so that we've got the right occlusal vertical dimension. And we just go by looking at the patient. If the patient looks like they're at peace, their face is at rest, it looks good, then we go with that vertical dimension. It's quite simply, if they look right, they are right with that. So once we're happy with that...
Can I just...
yeah, go on. Sorry. Yeah.
Can I just show the picture of the patient smiling with the wax rim in place? Because that, again, if we get... if you could transfer both of these pictures to us in the lab, that helps so much, because we get to use these as fantastic references for when we're setting the teeth. So it's not just about having the dentate picture, it's also about having that picture with the rim in the mouth, and we can make adjustments here and there where we see fit as well. Absolutely.
Thanks for that. Yeah, you can. It's really, really important. If that's delivered to the technician, it adds another dimension to it. So once we're happy and we're ready to fix these together in centric relation, or you might call it retruded contact position at dental school, what I do is I cut in the upper rim a groove, a good positive groove all the way through, and then squirt Futar D bite registration material all the way around, lots of it. So right into the grooves, and then squirt it right between the rims so that it overlaps, it lips over this front edge here, so that it means that then when Sam gets it back, they can articulate it properly. Did you want to say something about that, Sam?
Yeah, as a technician, when I see this, the wax rims held together with, you know, Futai D or something similar, it makes me feel so much better and so much more confident that it's an accurate jaw registration. I find that if you're trying to heat up the wax bite blocks, stick them together in the mouth, getting the patient to open and then bite together, you're always going to find that the patient will posture or they won't find that natural position. Whereas if you do the bite registration this way, you can get them nicely into position, hold them there, have a look, see that everything's correct and you're happy with it, and then just get them to stay still and stick everything together. It just makes everything so much simpler and so much more accurate. It's great. It's fantastic.
Thanks, Sam. That's brilliant, because I've forgotten to mention about that the patient, like for instance here, when I do this, the jaw registration stage, Claire's got photographic retractors in the mouth, and I can see the blocks are together, and all I do is just squirt the futar in. It's just brilliant way of doing it, much better. So yeah, I think the rim, carving the rim is the key to success with this. And we can just, once we put the teeth back, where they were naturally, this is, for instance, Anne wanted her teeth to look, she wanted them like the photograph, but better. That's exactly what she said. I want them like that, but better, please. And this is lovely work. And it's great, isn't it? You love it, don't you, Sam, doing this?
Oh yeah, I mean, it's really nice when you have all these extra bits of information and you can really go to town with aesthetics. And it just presents all different kinds of challenges, because to find a tooth like that, you can't buy them on cards. We spend a lot of time adding to teeth, trimming teeth, changing the shapes. And I mean, even to the point where we sort of give the denture a bit of history, if that makes sense. And we'll have a look at one tooth and decide, oh, that's had a bit of perio, and we'll put a bit of recession in there, or, oh, this tooth's a little bit swollen, and we'll make that. And because all these extra details just completely fool everybody else who's looking at it. It just makes them invisible as dentures.
That's right. So, if you look closely, you've got little cracks in there, and these cracks are, it's just a scalpel blade. These are Shotlander Enigma Life teeth. They're beautiful teeth. And then we can just characterize them. A blade, sharp blade in, sandblast it, and then just rub in a different coloured composite in there. You can put white or brown or yellow and run it down into a crack at the end of the tooth there. You could put a little chip in the end, and it just looks fantastic, particularly if it's offset. It's great. And natural coloured gums are so important too. For particularly for patients with a high smile line. So, and at the end of the day, I just want to put them back where they were naturally, the teeth. So, and the occlusion's right in the middle of this denture, just there. Even though there's a huge overjet, that's the middle of the denture, and the denture will remain stable in chewing because she's literally biting in the middle of that denture, and it's worked beautifully.
Dr. Sutton?
Yep.
Sorry, there was a question from Evelyn here. She's asked, does the bite registration paste increase the OVD if a lot is added?
No, not at all. If we go back to this picture, it's a good question. So the registration is taken just like that. So if you imagine the patient's in the chair now, they're biting together on those pivots there, and the Futar D is injected into that without the patient opening. So literally the futon just fits between the rims. It doesn't open it up at all. So it just goes, you know, we just squirt it in just like that. Does that make sense, Shivani?
Yeah, I hope so. Hopefully, I think Evelyn, hopefully understands that as well.
So we
the
don't
wax bite blocks. Oh, sorry, Finley. The wax bite blocks are always in contact.
Yeah, they're always in contact. They just remain in contact during when I squirt that thing in there. So good. Just we're nearing the end now. So it's we've got the other thing that is really interesting. I think in terms of all of this is that what I find is that because I've get patients bringing tons of pictures. You know, this is Dave here, and in this picture here, he is about 19, and just look at the difference in the length of his upper lip at the age of 62. You know, the upper lip, all our upper lips grow with age, but the relative tooth position of where his natural teeth would have been doesn't change very much. You know, there's compensation, dentoalveolar compensation. So when I'm carving the wax rim, I think about this as well, that the upper lip's going to grow, so they're going to be showing less tooth as the patient gets older, just purely because of the growth of that upper lip. So I'm thinking about that when I'm carving the rim too. So over to you, Sam, with this.
So yeah, this is another thing we do quite a lot, and it just adds an extra sort of level of sort of natural aesthetics. Is I've yet to meet anybody with naturally perfectly straight, regular lower anterior teeth. They always seem to be, you know, a little bit either overlapped, or you may have diastemas. It's something that, again, it just tricks the eye and just makes the denture disappear.
So, okay, that's great. So next, just a fantastic little tip particularly for free end saddle partial dentures or composite rests, which can just be bonded on to these lower anterior teeth, just like that. There, so we can glue those on, and this stops the denture from wanting to move down and distalize. They're just fantastic. So if you now visualize, this is a lower incisor here, and in the past I used to have to cut in a little rest seat just there, but instead now what I do is I build that up in composite, and then the chrome framework can fit over it just like that. And that prevents the denture from wanting to move backwards and move down. And they look like this in the mouth here. You can just see them there, just beautiful little, almost like climbing wall hooks there. So, and what I advise is, you know, as a young dentist or people just starting out with doing this type of work, I think it's good to get the technician to wax it up first and then give you something to enable you to actually do it. Okay,
yeah,
Sam.
in the laboratory we can produce, you know, like a bleaching tray type appliance where we'll wax these rest seats up onto the back of the teeth. And also we have the benefit of being able to put the cast onto a surveyor and remove all the undercuts and everything like that. So it just kind of removes that guesswork, so to speak. We'll then create a pull down with a bleaching tray material, and then it's really easy on clinic. You just drop a tiny dab of composite into each of those spaces, place them over the teeth, and then go through your usual curing procedures.
So yeah, so what we do is, if we go back, so the teeth will have been etched and bonded, place bond, and then the composite can just be placed straight onto the teeth there like that, and then we can zap the composite through the pull down, and then just take that off, and then just with a diamond, with that crown prep diamond, I just reshape or take any of the excess off, and then using a enhanced finishing burr, just polish them up. I always warn the patient, because this is like part way through the process, they may feel that a little bit with their tongue, but my patients get used to it beautifully. That it's really not a problem. And then the casting, the actual chrome casting itself, you can see these rest seats that just are where they fit into the chrome. And, you know, if you look on this model here, they're only tiny, just little tiny hooks there, but it's just like allows the chrome just to grip and hold really well, just like a climbing wall type arrangement. And you can see this lovely design. We're trying to keep it away from the gingival margins as much as possible to allow the patient's saliva to flow there, to reduce periodontal issues. And then the chrome framework just fits beautifully onto that too.
Dr. Statham?
Yeah.
Sorry, another question. Would the composite rests come off fairly regularly when the denture hits it during occlusion?
Not at all, no. I've been doing this technique for 7 years now, and I've had to replace one so far. The denture itself and the chrome framework fits so beautifully around, and it actually touches the natural teeth so well, and they're so stable that there's very little loading on the composite rest seat. So they're not actually loaded particularly. So if it does come off, it's quite straightforward to rebond it just using the denture itself. So the composite can be placed into that area there. That can be then fitted back onto the teeth, and then you can light cure it through the tooth, and then set it, and then take off the denture, and then make sure it's light cured even more. It's dead easy. But as I said, they don't come off, so it really isn't a big problem. It's a question that I get asked all the time, and I keep forgetting that people are going to ask that question, but it's a very logical question, and I think that, but it just isn't a problem. Next, I just want to just very, very quickly, is when I'm doing freehand saddle partial dentures, like this is Dave, actually, that chap with the lip that had grown. This is his lower denture there. And I always think of a freehand saddle just like a complete denture. So I extend it all the way up, just like we did we talked about in the lecture earlier this year that Sam and I gave to Liverpool Dental School. And so always fully extended. And then another great tip for partials, a little rule that no more than 2 clasps are necessary per denture. That's what we find works beautifully, particularly with the Scandinavian system that we use. It's great. We love gold clasps too as well. These are great. These 0.9mm gold clasps, don't we, Sam?
Yeah, it gives us a lot more opportunities to hide clasps away in a little bit deeper undercuts. Gold's a lot more forgiving than what cobalt chrome is. So we can get a little bit deeper, go a little bit more distal, really get them out of the way from where you would be able to see them.
That's it, absolutely. And if you look at his freehand saddle bit here, how it goes all the way up the retromolar pad, in the mouth itself, when we look there, you can see this is Dave's denture there, that the soft tissues of the tongue and the cheek just falling on that denture and holding it in place beautifully in this freehand saddle situation. And I'm still amazed that he coped beautifully with this, and we've not needed to put implants in underneath this freehand saddle part there. So the next, just the final little bit is, I think it's just so important to communicate really, really clearly with our patients about what we can achieve. And also, I do try to talk to them about neuromuscular control and about adaptation to dentures. So this video I'm going to just show you now is an x-ray video of a patient who's got a really old denture. It's about 30 to 40 years old, but watch how much it moves around when the patient eats. Well, the patient can eat beautifully with it. It's amazing. It's neuromuscular control in action. So the patient bites, and when they're chewing, that upper's tipping and the lower is shifting on its base massively. And yet the patient is coping really well with it. I'd like to think that the dentures that we make for our patients fit so much better than that, and don't move around as much. And I'm sure that is the case. But in order for a patient to get used to the denture, they have to adapt to it. So I've got to really talk very carefully and clearly with the patient before we even start treatment to discuss their role in the success of the dentures. I say to the patient that I can do 70% of the job, 60% of the job. If it's a difficult case, if it's a really difficult case, I'll say we can do 50% of the job, i.e. make a technically superb set of dentures, but we're still heavily reliant on your adaptive capacity to them. It's a little bit like learning to drive a car. You know, at the age of 17, it's really difficult, and we've got to think about it consciously, using the controls of the car. But over time, amazingly, and I do think it's amazing, our brains automatically adapt, and we can now, you know, a year down the line, you can drive without even thinking about it, and the car becomes one with you. It's like, you know, like a prosthesis, really. And I think learning to adapt with dentures is just the same. So it does take, we can design them and make them beautifully technically superb, but we're still reliant on that patient's adaptive capacity. And I think it's really important to get that message across right at the beginning, because I wouldn't need to talk to the patients about this sort of thing if they had this level of neuromuscular control. So we wouldn't need this lecture tonight if they all had. But what I'm trying to do really is to just always, even I want the patients in the under-promise, over-delivered category. I want to under-promise what I'm going to do and over-deliver, because if I say the dentures are going to feel like natural teeth, then that is just nonsense. You know, the patient, I've got to try to educate them with this too. So now, if you are interested in a lot of the stuff that we've talked about tonight, we've got so many resources on the website here. If you go to finlaysutton.co.uk and you go onto the speaking part there, and then if you just scroll down the speaking part of the page, there's absolutely loads of resources. And going into detail, there's 3 BDJ papers that I've written with John Besford and talking about what we've talked tonight, and lots of other very, very interesting articles and useful extra bits of information if you're interested. So, and also, you know, if you do have any questions at all, then don't hesitate to send me an email at this place, and I will contact you. And thank you very, very much indeed for listening. It's been great chatting to you. So,
thank you so much. Thanks so much for that talk. It was brilliant. It was really insightful.
That's okay. Absolutely. Not
I'll just double check if anyone. I'll just double check if anyone has any questions.
Yeah.
I think I had one question about the dentate photographs.
Yeah.
How recent would you want those photographs to be? Like, is there a sort of cutoff point in terms of in terms of like how recent they need to be?
Yeah,
Or
there is actually. Yeah, there's the cut-off point is the age of 8. So, and the reason is that from the age of 8 upwards, our interpupillary distance, it doesn't change. It's a stable position for the rest of our lives. So if we've got a picture of a person at the age of 8 smiling, we can measure the interpupillary distance on the photo. You know, we can blow it up on the screen. So we can measure that IPD. We can measure the actual size of the upper central incisors. And then we've also got the patient in the chair. So we can measure their PD, and we can then calculate the true size of the upper central incisors, which means we can then select the right size and shape of teeth to match that patient. So 8 upwards. And you know what? It's just a conversation that patients always say, I don't have any photos of when I had my natural teeth. They always come out with that one. It's just so frustrating. But I'm really insistent that they go looking, and it's amazing what they find, because with really good cameras, we can photograph a little tiny picture that's like a little black and white thing, and then blow it up on the screen, and it shows us buccal corridors, shows us lip support, shows us loads of stuff. It's really, really good.
Brilliant. Okay, just got a question come through. So I've got from Viraj, what are Dr. Sutton's thoughts on the RPI system?
So the RPI system, I don't think it's, I think it's consigned to the grave of history. I really think it's, I feel very strongly that we should not be teaching that at all now. But however, you'll probably have teachers at Liverpool that will push it and will defend it greatly. I think the Scandinavian approach is much better. The Scandinavian approach is where many more of the teeth are used to support the denture, and the elements that sit on the teeth are much bigger to generate proper support from because the teeth are great for supporting a denture. So the RPI system allows the whole thing to tip into the saddle area, and a lot of patients are bruxist and heavy on, so the denture itself is quite often constantly sore on these free end saddle situations, whereas with the Scandinavian system, with all these lovely composite rest seats, fully extended, it doesn't hurt the saddle anymore. So that's what I think about it.
Well, also, just to add, something that I found really interesting when I started working at the practice was I saw Finley fit a partial denture with free end saddles, and I was amazed at how much support was gained from the retromolar pad, and just how little rotation. If the denture is properly extended over the retromolar pad, it eliminates so much of that rotation, so it becomes a lot less of an issue putting torquing forces onto teeth.
That's right. But I suppose in an exam you shouldn't write that. The RPI system still.
I'll just quote you just saying Dr. doesn't absolutely hates the RPI system. You can ask him about it.
You can do. It's fine. It's not a problem.
Okay. Well, we haven't got any more questions come through. Yeah, I think it's going to say thank you both so much for tonight's talk. It was really, really insightful. I think I speak on behalf of everyone when I say, yeah, thank you so much for this.
That's absolutely fine. Thank you very much for inviting us.
Yeah, anytime.
Thank you very much.
Yeah, okay. Anyway, good luck and all the best.
Yeah,
Okay.
thank you.
Take care, guys.
Yeah,
Take
bye-bye.
care.
Bye.
Bye.